All right, welcome everyone. As you settle in, we're going to get started here. Welcome to this CME Symposium on Kidney Cancer. We're going to discuss cases from the community and get insights from the expert faculty to my right here. I'm Brian Rini. I'm from Vanderbilt University, and I'm joined by Laurence Albiges from Institut Gustave Roussy, Toni Choueiri from Dana-Farber, and Prof Powles from the Barts. As I'm sure you all know them, they're excellent. We have an all-star panel here. We're really looking forward to sharing some insights with kidney cancer and talking about these cases. This is supported by Aveo, Eisai, Exelixis, and Merck, so thank you for your support. And you can see the disclosures there, and I'm going to go over disclosures briefly. I'll just click through these. These are all in your program. Dr. Powles, I think, has the award for most disclosures. Congratulations, Tom. Oh, maybe not. So here's our agenda. Basically, each of these 4 modules will be a video or 2, which is a patient case presented by a community oncologist on kidney cancer. We'll have a very brief discussion around that case and some salient clinical questions. And then we'll have a didactic bite in the order that you see there about various aspects of kidney cancer. And each module will basically follow that same format. And that'll take us through about an hour and a half. And these are all the community oncologists that you'll be hearing from. You see it's a really diverse group from across the U.S., and I think there's 10 total. These are the first 6, I guess 9, and these are the other 3. So really, these are community oncologists in the trenches taking care of a lot of kidney cancer. They'll briefly present a case, about 1-minute video, and again, then we'll talk about some of the questions around that particular case. With that, we'll kick off the first module, which is around adjuvant therapy of immune checkpoint inhibitors. And before we get to Dr. Powles' didactic, we will get to the first video.
Good evening, everyone. I'm Neil Love from Research to Practice, and welcome to our real-world case library. Tonight, focus on the management of renal cell carcinoma. And the first case is presented by Dr. Swati Vishwanathan, a 61-year-old woman whose status post-radical nephrectomy.
Her final pathology showed clear cell T3 and 0 disease. And what I want to know is how are they navigating this discussion in clinic? Because I feel we have some conflicting data. Pembrolizumab has shown DFS benefit, whereas atezolizumab and most recently nivo-ipi did not show any benefit. Do they still think pembro has a role? Are they offering it to their patients? Based on the DFS benefit, I did discuss pembro with this patient for a year, but she was very concerned about the risk of autoimmune toxicity, so she has chosen surveillance. She refused it. And the same question I have is for stage 4 NED patients. Some patients who want every single thing done, and then there'll be patients who will be like, okay, I'm done. I don't care. I don't want any more treatment. She was one of those who felt that she would be one of those unlucky who would have all those autoimmune side effects. So she didn't want to take the risk.
So the questions here are, what are your criteria to use adjuvant immunotherapy for RCC? And how do you discuss this with patients? The other question is, what about the patient who's rendered stage 4 NED by local treatment of oligometastatic disease?
So let's take, Toni, why don't you take the first part of that? You led the adjuvant pembro study. Are you offering it to everybody? Would it fit into Keynote, a subset? How do you approach, briefly, how do you approach this in the clinic?
Yeah, I'm offering it actually to patients that meet the eligibility criteria on Keynote 564. I'm even extending it to some folks that where pembrolizumab as a single agent in metastatic disease have shown activity, like in papillary kidney cancer and unclassified RCC.
And Tom, what about the conflicting data? You did the commentary at ESMO around this, where those 3 negative trials were presented. So, we don't have time to sort of go into the deep dive of all the trials, but when you're talking to a patient about this, I guess the biggest question is, how do you bring in that data? How do you bring in those data, the negative data?
So I think it's reasonable to say that there is conflicting data which can't be explained easily. I think Tony's right. I wouldn't offer pembro outside of the indications of the trial. So I wouldn't be offering it to papillary. Actually, I think it makes him wrong, doesn't it? Not right. I think Tony's wrong. I wouldn't be offering it personally to papillary cancer patients. I'd like to see papillary cancer data before we do that. But I think for those patients with high-grade T2, T3, T4, N1, M1 NED, I think that population is a reasonable conversation. I think until we see final OS data, I think there is a need to put the data into context which is there's a very strong DFS signal. But I think in the same conversation, there needs to be a discussion about a 10% chance of serious adverse events, life-changing toxicity ranging from diabetes to neurotoxicity. And I think there also needs to be a discussion to say there have been other trials, and for whatever reason, those trials haven't come home. And part of my 8-minute discussion, I hope, will cover that.
You're using up most of your time right now, so. And Laurence, what about stage 4 NED? I mean, they're at the highest risk of recurrence. The trial had peculiar eligibility around that. How do you handle that in practice?
Correct. So to this question, I think it's very important to explain to the patient that indeed we have a trial that answers that question. However, one could also argue that in a metastatic patient, systemic therapy combination is considered as standard of care. So ultimately, I try to see if my patient is matching exactly the criteria of the trial, and in this case, I would discuss adjuvant pembrolizumab.
Okay. And I think we're going to move on to the second case.
The next case is presented by Dr. Justin Favaro, a 50-year-old man whose status post-radical nephrectomy for a T3A-N0 11-centimeter clear cell carcinoma with renal vein invasion.
I treated him with adjuvant pembrolizumab. After 2 cycles of pembro, his creatinine rose from 1.1 to 1.8, and his estimated GFR came down from 94 to 52. At that time, I stopped the pembrolizumab. I got a nephrology consult, put him on prednisone, 1 milligram per kilogram. When you see patients getting adjuvant pembrolizumab in the setting of a nephrectomy, what do you do if the creatinine goes up? When do you decide to stop treatment? And what are your parameters for considering restarting treatment?
Dr. Priya Rudolph also has a patient with autoimmune complications of adjuvant pembrolizumab, a 67-year-old man who had an 8.5 centimeter grade 3 RCC removed surgically and was then started on adjuvant pembrolizumab.
Unfortunately, as much pembrolizumab as I have given, this is literally the only patient that I came across where I had to discontinue it because of severe musculoskeletal pain. His hands were obviously swollen and he could not even make a fist. I held the drug, put him on a prednisone taper for about a month, and he responded really well to prednisone. However, when I started him back on treatment with pembrolizumab, unfortunately, he had recurrent symptoms of joint swelling. So he finally decided he did not want to continue treatment with pembrolizumab. So my questions were, do people even use adjuvant sunitinib nowadays? And the role of ctDNA monitoring, is that something that has been looked at in renal cell carcinoma?
So, in summary, input is requested on renal dysfunction with IOs and musculoskeletal complication of IOs, and also the potential role of ctDNA in managing these patients in the adjuvant setting.
So a lot of questions in there. Laurence, let's start with you. I think we're getting at benefit risk of adjuvant pembro in this circumstance. What's your threshold to stop therapy? And then do you ever restart in somebody who's experienced immune toxicity?
So just a first answer, as Toni says, I think it's important when you decide on adjuvant with the patient to express the risk of serious adverse event that could actually last. Second thing is basically if this side effect is impacting my patient's life, obviously I need to discontinue. And in some cases, you do need to admit the patient and check for, like labs or more expanded analysis so that you would catch a serious adverse event. So ultimately, in this situation, you have to discontinue. I would not restart in the adjuvant setting when I had faced a grade 3 or 4 toxicity, but it's depending on the type of toxicity.
So generally, if you have to stop for IO-mediated toxicity, you probably wouldn't restart. Yeah. Toni, anything to add? I mean, in terms of like that threshold to stop? Mine is pretty low in this setting, but I'm just curious.
I think in the setting of adjuvant disease, where patient could have been, in theory, cured by surgery alone, and where 1 to 2 doses could have done that effect. Remember, the timeline we use, 1 year for adjuvant treatment, is totally arbitrary. We don't know if patient need 2 years or 6 months, so low threshold to stop. One more thing just to add here for the toxicity. I do believe that the second toxicity is probably polymyalgia rheumatica, which is not uncommon, and we see and respond to low-dose steroid. and can be worked up. The first one, I don't know if it's related. If I have to guess, it's probably unrelated, especially if this renal dysfunction is just an elevated creatinine, which fluctuates a lot after a nephrectomy in patients that are older, like renal cell cancer.
And Tom, last question. You're a ctDNA kind of guy. Do you ever use it in kidney cancer? Do you ever use it clinically, not in a research setting, but clinically?
Not clinically, and I think that the ctDNA data in kidney cancer is a much harder ask than in some other tumor types, which are more noisy. There are issues around driver mutations in kidney cancer, and the likelihood of being ctDNA positive is much lower. And so the chances of it being successfully developed into an MRD tool is currently more challenging. I think in the fullness of time that will change, but we're probably 4 or 5 years behind what's happening in lung and colorectal and bladder cancer.
Yeah, I agree. All right, and with that, we'll turn the
Here we go.
podium over to Dr. Powles to talk about adjuvant therapy.
I'm really excited about
You have 8 minutes.
8 minutes.
We were 3 minutes ahead in the previous one, is that right? Can I buy those 3 minutes?
No way.
I've got time some questions afterwards. I'm pretty confident I can do this really fast. I've been given 8 minutes to talk about all of the adjuvant immune therapy data. I'll try and do it sitting down. Can I stand up? I feel a bit more comfortable standing up. So here we go. There was a question about VEGF-targeted therapy. I think the VEGF-targeted therapy story is a negative story, and I know some people will say, well, hold on a second, there was one positive trial and a whole lot of negative trials. Is that not exactly the same as we've seen in the IO story? And the reason there's a difference between the two, in my opinion, is I think the biology between long-term durable remission associated with immune checkpoint inhibition is there in advanced disease. It was never there with the VEGF-targeted therapy. Number one. And number two is we never saw a hint towards any survival signal with the VEGF-targeted therapy. However, as you know, the current survival signal is trending in the right direction in the pembrolizumab study. So I think there are distinctions between the two. I think it's important. The previous study was the ASSURE trial. That was the big negative sorafenib, sunitinib placebo study. This is the positive S-TRACK trial. But look on the right-hand side, that's the OS Kaplan-Meier curve. So essentially, I think VEGF-targeted therapy is good at treating early disease. It's a good DFS drug. I was surprised more of the trials weren't positive at DFS, but it's not a good overall survival drug. And that's why I think the two are different. When we look at the adjuvant and first-line immune checkpoint inhibitor studies, we can see on the left-hand side a whole string of positive trials in history going back in time, with the exception of the two reds there being the PD-L1 therapy studies. But the story in the adjuvant setting and neoadjuvant setting has been more complicated on the right-hand side, with 3 negative trials, a positive PFS study for pembrolizumab with OS trending in the right direction. And there's also a third arm of the ipi-nivo trial, which I believe is really important. And that third arm is adjuvant nivolumab. It's adjuvant nivolumab. And we haven't seen that yet. So this is the big question, and this was an editorial which Ursula wrote recently in Lancet. And what Ursula was saying was, how can we account for these differences highlighted in that previous case? Is it trial design or imbalances in the trial design causing these differences? And I don't think that's the case. I think that the trials that I'm going to talk about are actually really robust. They're all about 1,000 patients, and they're well-designed studies with the exception of one, which I'll talk about in a second. Really important question, how much does ipilimumab add to nivolumab in the adjuvant setting? Next question is, does ipi need to be given for a year, or can we get away with 6 months? You'll know in the ipi-nivo trial, it was only 6 months of therapy, and the ipi was given every 6 weeks, not every 3 weeks. Was tinkering with the ipi dose relevant? Are all PD-L1 therapies the same? That's a really important issue. We seem very uncomfortable having that conversation, but I think we do need to start having it, and I'm happy to take part in that. And then, is there a future tool for neoadjuvant therapy? So I'm going to talk about 4 studies very quickly. The pembrolizumab study we've talked a bit about already, which is the positive study, atezolizumab 010, the nivolumab neoadjuvant trial I'm going to talk about, and then the 914 negative ipi-nivo trial. For all intents and purposes, the 3 adjuvant trials were very, very similar. The neoadjuvant trial was very different. It had a lower risk population, and I'm not going to talk too much about that today, but I am going to talk about the other 3. 564, this is the updated PFS and the DFS and the updated OS signal, 0.63, 1 in 10,000 chance of the trial being positive by chance alone. So this is a very positive DFS signal with OS trending strongly in the right direction. So this is an impressive study, I think, in terms of the data, early discontinuations and steroid use, 20% discontinuations. It's a bit higher than we saw in the metastatic setting, and it came back to what Brian and Laurence said before. When we're running into toxicity in this population, we're more comfortable stopping the drug earlier. We don't want to push patients into life-changing toxicity, and I think that's reasonable, and therefore steroid use is lower. You can see across broad subgroups of patients, remember this is intermediate and high-risk disease, broad subgroups of patients, you can see it benefiting all of these patients, all of the dots on the left-hand side of the curve. This is the adverse event profile. Toni presented this, I think, 6 months ago, perhaps a bit longer, and you can see the timing of the adverse event occurring at the beginning of the disease process there. I think someone's doing that for me, which is kind of you, Brian, if you're doing that. Terrific. So we have a really positive and nice trial, and everyone was happy. And then, of course, the atezolizumab study came out, and this is a negative study. You can see a real lack of disease-free or overall survival benefit. The hypothesis about why this is different, and some people say PD-L1 therapy is not as active as PD-L1 therapy is not as active as PD-1 therapy in renal cancer. But actually, if you look, single agent atezolizumab does have activity. You can even see 11% CR rate in Emotion 150. So single agent atezo does have activity, but it didn't seem to get over the line or have any signal that we can see in this adjuvant setting. I think many people are comfortable to say there are differences between PD and PD-L1, and that part of the conversation was quite straightforward. But this was more difficult, because if adjuvant pembro is positive, you would expect adjuvant nivo to be positive if you think PD-1 therapies are all the same. And we think that the addition of ipi gives you a 10% boost on top of nivo. So it should have been even better. But you can see here, no DFS signal. This is the overall survival signal. This OS signal wasn't presented at ESMO, but it was in the Lancet paper last week. You probably haven't seen this curve before. You can see not even a trend towards OS. So this is a negative study. And I think one of the key issues here, as I said before, it's only 6 months of therapy. IPI was given at a slightly different schedule, but also higher discontinuations than with adjuvant pembrolizumab. I think it was quite difficult to give this combination. As I said previously, more discontinuations than we see in the advanced setting in adjuvant. And the reason for that is we have a lower threshold to stop therapy. And when you add IP on top of that, it might be actually that we just weren't getting the drug into the patients. There is some evidence that that may be the case. This is a very quick slide. Does IPI actually add anything to nivo? And I think most people believe it does improve your response rate by about 10%. Whether or not it has a tail on the curve, we don't know. We haven't seen data comparing nivo with ipi-nivo. There's a study called 8x8, which we're all really excited about, comparing ipi-nivo with nivo. I think there are more questions around ipi today and how much it's adding than there was 3 or 4 years ago. And obviously having a big negative randomized trial for ipi-nivo, while there's a positive pembrolizumab study, does mean we should be asking those sorts of questions. I think it's reasonable to have that discussion. This is the neoadjuvant trial. The neoadjuvant trial had a lower risk population. We lost a lot of patients to follow up along the way. I don't think it's fair to say that this defines there will be a negative adjuvant Nivo trial. And I don't think this completely kills neoadjuvant therapy in the future. I think we should be doing randomized phase 2 neoadjuvant trials, perhaps with a slightly different design. What does the community think is the explanation for why these trials didn't work while the Pembro trial did work? Well, I think, as I said before, in the neoadjuvant trial, the feeling was it was the wrong patient population. In the atezolizumab study, the feeling was the drugs are different from each other, PD-1 and PD-L1. And then in the ipi-nivo trial, it was felt around toxicity. So multiple reasons why these other drugs may have failed, but this isn't necessarily correct. This is just the hypothesis about why that was the case. I've just about finished on time. I'm not going to go through my summary in great detail beyond to say the pembrolizumab adjuvant study has a very strong positive signal. There are debates about PD-L1 versus PD-1. I think the ipi-nivo study is actually a mystery, and I don't think that it's easy to explain why that didn't work. And I think the last point is really important, that patients need to be aware that pembrolizumab delays progression-free survival with a trend towards OS, with about a 10% chance of life-changing toxicity. But they should also be aware that these other trials have not come home in the same way, and so there is some uncertainty in this environment. Brian, thank you very much.
Thanks, Tom.
Thank you.
I've known Tom for a long time. That might be the first time he actually stayed on time. That's
well, you put a lot of pressure on me.
Yeah, I know. All right, we're going to move on to the second modules around selection of first-line therapy. And before Toni talks, we have a case.
The next case was presented by Dr. Helen Moon, a patient who presented with inguinal pain, was found to have a large renal mass, hyaluradenopathy, and metastatic disease to the lungs.
He's a 71-year-old high school history teacher. He was a marathon runner, just basically as fit as can be. He enrolled on the PDIGREE study, which everybody starts with combination immunotherapy, in this case, ipi-nivo. And depending on their response, it's an adaptive study that sends them down specific arms. And so in his case, ipi-nivo didn't do anything. He didn't have any side effects, but then the restaging scan shows that he has progression with a liver mets. And so the way that that study works is that he randomizes to a single agent TKI, in this case was cabozantinib. He does seem to have a response, though I would tell you fairly short-lived. So from the expert panel, are there patients that they would prefer IO, right, ipi-nivo, versus any one of the TKI-IOs? Is it ease of use? Is it insurance? Do they truly believe the tail of the curve on one is better than the other? And now with the COSMIC data that came out with the triplet, do they find that compelling enough that if you got this patient now, 70 years old, runs marathons, so entirely hale and hearty and fit, would they have offered triplet therapy?
So in summary, the question here is the approach to choosing between an IO combination of ipi-nivo and an IO-TKI combination, and which one? And finally, the role, if any, in your practice of triplet induction.
So Toni, this seems perfect for you since you're involved in a lot of these studies, PDIGREE and COSMIC. There's a lot here, and I imagine you're going to talk about it, but maybe just sort of a preview of your talk, a summary of how do you select therapy? Are you giving anybody triplet based on COSMIC? Maybe let's start there.
So the straightforward answer, no, not yet triplet. It's not approved. In the near future, if this triplet combination get approved, I think patient with significant disease burden may be the one to do. Now regarding IO or IO-TKI, that's the question in every they practice. I can tell you, Brian, not having favorable risk, having sarcomatoid is what pushed me toward nivo-ipi. Significant favorable risk or significant tumor burden, with progression is IO-TKI. Everything else in between, you can do either. As simple as that. There is no other way. You stick with a combination, and you give it.
And just quickly for the audience who may not know much about PDIGREE, you were involved in designing that. What is that, and when might we see results?
Yeah, so this is an intergroup frontline trial where patient with intermediate poor risk get all nivolumab, ipilimumab. Then based on the response they get, if they have CR, they continue nivo-ipi for a year only. If they have progression as best response, immunotherapy didn't work, then they get cabozantinib. And the thing is, if they don't have PD or CR, and that's estimated, let's say 10% CR, 20% PD, those 70%, typically what do? They get nivolumab maintenance. Where here, those patients are the ones that are going to be randomized to nivolumab maintenance. That's the control, or adding cabozantinib.
All right, thank you. All right, we're going to go on to a couple more cases.
Dr. Victoria Giffey has a 70-year-old man with poorly controlled hypertension, also on chronic hemodialysis, who was diagnosed with extensive metastatic RCC.
We elected to give him ipilimumab, nivolumab, and after his first dose, he developed grade 3 autoimmune hepatitis. His AST and ALT were both in the 400s. It very quickly responded to prednisone. We talked about our educated guess that most likely it was the ipilimumab, and do you want to try the nivolumab? He's now over a year on nivolumab alone and has very little disease left. You can see that actually a lot of the lung nodules you can see on the scan on the left are not on the scan on the right. He has very few little scarred lung nodules left. If you're giving combination CTLA-4 and PD-1 immunotherapy and you have an immune-related adverse event, is it a general strategy, like in this case, to hold the CTLA-4 and continue the PD-1? Or if it's very severe, do you just abandon both?
Dr. Philip Brooks also has a patient on first-line ipi/nivo with an autoimmune complication.
Oh, this is a really nice guy. He's a plumber. He did develop hypothyroidism, but after being on thyroid, he was having more fatigue than I was comfortable with. And we did studies and he was clearly hypoadrenal and felt much better when we put him on steroids. And on replacement, he feels perfect. Such a high percentage of my patients develop hypothyroidism that I follow that very closely.
So in summary, we have two cases of patients receiving first-line ipi/nivo with autoimmune complications. The specific questions are, how often do you see autoimmune hepatitis in this setting? And in terms of adrenal and thyroid dysfunction, how long do you continue screening patients for these problems? And finally, how do you adjust your treatment plan for metastatic disease in a patient on chronic hemodialysis?
So lots of questions there. Laurence, let's start with you. So that second sort of bullet point there, you have somebody who has significant, call it grade 3 autoimmune toxicity after a dose or two of ipi/nivo. How do you handle that in terms of restarting therapy, one or both or neither, I guess?
So the chance I have in my institution is that we have an IO toxicity tumor board, and so we would discuss this case. And in quite a large number of cases, actually, we do restart single-agent PD-1, so here nivolumab. But what I like in those different cases, Brian, it highlights the fact that a patient that had one toxicity has actually a likelihood of 3-fold higher to have another immune toxicity. So yes, we need to screen for other toxicity, even when we have discontinued systemic therapy.
Are there patients, do you ever, like, somebody has grade 3 IRAE on after 2 doses, do you ever use a scan to determine if you're going to restart? If you scan them and they're wildly responding, might you just watch them or no?
Absolutely. Anyway, you're not going to restart right away. Usually you're having steroid use and you're tapering your steroids. So during that time, you'll have a CT scan. And in a patient that have complete response, then it's a no-brainer. We will not resume therapy.
How about in this patient that Dr. Giffey showed? She had just residual small pulmonary nodules. You said CR, but most patients aren't going to have that.
Yeah, near CR, I would do the same. The only situation is when you're very early on, 1 or 2 infusion only, when you have not yet seen a tremendous diminution, then in this situation we would, in case of handling properly the toxicity and getting back to grade 0 or grade 1, then we would resume PD-1 single agent.
And Tom, how about that third bullet point on when do you discontinue immune therapy? Let's take the toxicity piece out of it, because we just talked about it. But you have somebody who's 6, 12, 18 months out, they have a few lymph nodes and their lung nodules have disappeared. When do you have that conversation, either with ipi/nivo or with IO-TKI, about stopping and observing? And again, take the toxicity considerations out for a second.
So there is some data kicking around which is treatment-free survival, and Mike Atkins, I think, is presenting some. And the principle of that is those individuals who get into trouble with toxicity stop therapy, and then they're out. What's their outcome? And that's very different from for stopping therapy in patients by choice. My current take on this is the pembrolizumab data gave 2 years of therapy, and I think for me that's kind of the minimum in advanced disease. I think from there, stopping the pembro at 2 years, that's what we did in the studies, and the hazard ratios for the LEMPEN study and axi-pembro are for survival look pretty good to me. So I think it's reasonable to stop at 2 years, and that includes nivolumab. I think for nivolumab, because in the trial it kept going, one can have that conversation with patients. Some patients want to keep going. I mean, the original goal, and of course Dave McDermott would be, if he was here, would be saying our goal was to give a period of therapy and stop therapy, cure patients, and patients shouldn't be on therapy for life. And so that conversation needs to take place. One of the things that I'm most anxious about is actually I think it's harder to give VEGF TKI therapy chronically than immune checkpoint inhibition. And I think it's, perversely, I think it would have been better to do it the other way around, to give a finite period of VEGF TKI therapy and keep going with the immune checkpoint inhibition, because the VEGF TKI therapy is not associated with long-term durable remission anyway. And there was a study called the STAR study that was published in Lancet Oncology last week, which looked at intermittent sunitinib or pazopanib in a different era, except it looked like survival with these treatment breaks doesn't seem to make a big difference. So I think actually you can stop both therapies. And I think that if you do it before 2 years, I think that's quite brave, and I wouldn't do that.
So if you're giving IO TKI, you stop all therapy in 2 years, including the TKI?
I think it wouldn't be a totally unreasonable discussion with a patient.
Okay.
It's not currently what I'm doing. I'm currently saying the standard is to keep going, and this is what we do, and we do the standard. But lots of patients come to us at this point having 3 months off here or 2 months off there. And I'm not religious about anything particularly, to be honest, but I'm not religious about giving axitinib until you die.
Toni, what's your practice? I think the practice patterns are all over the place, and frankly, none of us really know what to do. But in terms of discontinuing therapy in the absence of toxicity, if people are toxic, if patients are toxic, that makes it easier almost, right, to decide, because you want to back off. But if somebody's sort of cruising along at 12, 18, 24 months, presumably at that point they're responding, CR, near CR, good response. Do you have one approach, or how do you approach the clinical situation?
Yeah, unlike Tom, I'm quite religious. So usually, to me, a CR or a near CR, which recently has been more so defined as 80% or more shrinkage. We've seen the data from Checkmate 9ER. We've seen the data from 426. I don't think we've seen the data from Checkmate 214, but 80% or more, since we have this trial, the tumor measurement behaves almost exactly like a CR in terms of progression-free survival and overall survival. So I've been telling the patient to stop, but I have to be honest with you that there are patients that are tolerating therapy very well that actually do not want to stop, and we have to take that in consideration.
And how about the TKI?
I do stop both at the same time, but tumor shrinkage significant is what's important. For patients that still have a significant disease burden, but they have been on therapy, let's say 12, 18 months with stability, I actually do not stop therapy.
Laurence, anything to add in terms of how you approach this?
No, except that 214 data were presented 2 years ago.
Thank you. Probably by me, but I don't remember.
Yeah, I tend to do the same. I stop IO at 2 years. I'm a big TKI drug holiday interrupter. So as Tom said, I think it's way more important early on. I think by the time you get to 2 years, I'm not sure it's adding a whole lot for most patients, but as you can tell, there's not great data, right? I mean, we all sort of rely on anecdotes and just our clinical experience. There's not great data to guide. Any comments on that first bullet point about patients with metastatic disease on hemodialysis? Do you take a different approach? Does anybody treat them differently?
So these are, the PD-1 inhibitor are antibodies. That shouldn't be an issue, despite they haven't been, used much specifically on hemodialysis. And the TKI are liver metabolized, so there shouldn't be an issue. The issue only, and this is work we've done at our shop, is that these patients may be more prone to side effects in general because they do have usually other comorbidities, and so have to be careful. Sometimes I start at lower dose, the TKI.
And Laurence, I think maybe you mentioned this in your answer before about screening for thyroid. Dr. Brooks, I think, brought that up. How often are you checking TFTs? When are you replacing at the slightest abnormality? Are you waiting for symptoms? How do you approach that?
So thyroid toxicity, I do screen on a regular basis, at least every 3 months. And I tend to replace when TSH is above 10 and not before, but this is something that you can discuss. With regard to hypoadrenalism, this, of course, is less frequent than the thyroid toxicity. However, it's the one that is tricky because it's, like random fatigue or sometimes a bit of nausea. And I think it's important to check that on a regular basis. So I used not to do that regularly, and now I'm doing it every 3 months.
You're checking a cortisol every 3 months?
Cortisol.
Okay.
Yeah, I have not been doing this. This is an insignificant side effects. It will manifest itself clinically easily, and the more common side effects is the hypopituitarism rather than the hypoadrenalism.
Tom, last comment on any of these monitoring? I think, everybody does it differently because we don't really know what to do, but how often are you monitoring for thyroid or adrenal or?
I think people routinely monitor thyroid. I think people don't routinely monitor adrenal. I think one of the issues with cortisol is that it depends a bit on the timing of your clinic. If it's late in the afternoon, many patients are going to have a low cortisol, and you're going to be phoning them up, dragging them back to hospital. So we would be, if patients were lethargic, we'd be measuring a 9 a.m. cortisol, but we wouldn't be doing too many random cortisols.
Yeah, agreed. All right, we're going to move on to Dr. Choueiri's talk. He's going to talk about selection of first-line therapy for metastatic kidney cancer. Tony?
Okay. So Checkmate 214, we did talk about the IO study. As a reminder, this was, the first large study against sunitinib, where, interesting enough, 3 co-primary endpoint, PFS, response rate, and overall survival. First time we see a TKI-based approach with the combo of nivo-ipi that did show activity actually in phase 2 study with response rate 42%. Same response rate on the phase 3. This is one of the few times I remember. But what I wanted to show you here in this slide is that with different data cutoff, with a minimum follow-up between 17 and 60 months minimum follow-up, here, the combination stood in terms of overall survival, the test of time, with a hazard ratio that was around 0.6, something I'll show you later we have not yet seen with VEGF TKI plus IO. This is the example. This is the one of the most recent follow-up, median 67, minimum 60 months. 60 months follow-up, and you can see the overall survival here, 0.72, still, quite significant here. Let's go through some of the VEGF IO. These are the one I put here, and these are the one actually that are approved by the FDA. Quick glance at what are these studies. First of all, they are more similar than different, and they have the same control arms, sunitinib, at the same dose, and they are all large and well-powered for the primary endpoint. Sometimes they have co-primary endpoint. The one different here is the most recent one, CLEAR, which attempted, beside the VEGF-IO, the pembrolizumab, to have a non-IO arm of the combo of len-everolimus, which already we know approved post first-line VEGF TKI. So this is the highlight from Keynote 426. This is a study led by Dr. Rini and Powles, and this is the median follow-up. The response rate stayed the same. If anything, the CR get better, the PFS around 15 months, and we're gonna see along these studies, the hazard ratio, which was one of the most impressive ones at 12 months follow-up, of 0.53, I think with times, despite being statistically significant and clinically relevant, it started drifting. We didn't see that with nivo Javelin Renal 101 is a combination we actually use less in practice because of the absence of OS, despite the PFS advantage here, whether in the overall population or in the primary endpoint of PFS in PD-L1 positive. This is one of the last updates here in OS that has a ratio less than 1, but it's not significant. Checkmate 9ER, the smallest of this trial, was the primary endpoint of PFS here. Easy to remember, 8.3 sunitinib times 2 equals 16.6. And that is the PFS, but also this study had an OS advantage, and we are going to see at this GU ASCO with Mauricio Burato from Chile, the 44 months median follow-up, but again, the hazard ratio 0.6, 0.66, 0.7, and the PFS and the response rate stay the same. Like Keynote 426 of pembro-axi, the CR rate with time gets better and gets over 10%, 12.4% here. This is the Borato oral presentation here with 44 months median follow-up. The OS remain significant, and I invite you to go to his talk, which is on Saturday. So we will also present something really quite interesting, but somewhat on the negative side. The first analysis, biomarker analysis from a PD-1, that's Nivo, plus VEGF-TKI data set, looking at PD-L1, c-Met, CD8, and several gene signature here. But the bottom line is that what we found significant for PD-L1 plus VEGF inhibitor, a lot of work from Bob Moser, Brian, Tom, and others with atezolizumab plus bevacizumab or avelumab, both PD-L1 inhibitor plus axitinib, may not actually apply to a PD-1-based therapy. So more to come on February 18, early in the morning, have to wake up, present this. CLEAR is the last one, the study I told you that had an interesting everolimus arm that I will not tell you about because the hazard ratio for OS went the other way around over 1, so this is not approved. What works second line doesn't work first line, and we'll see the same trend, although we're gonna see this year another probably cut off of the data. Hazard ratio significant for OS, 0.66, become 0.72, but this is the longest PFS we've seen to date, over 2 years. We have not seen that. Is that the combination? Well, perhaps. And the highest response rate, NCR, but also, unlike Nivo-IPI study, unlike Checkmate 9ER, unlike axitinib, more so similar to pembro-axi, the proportion of patient with good IMDC risk factor is higher. To how much that contribute? Ask Brian. Treatment-related AEs on phase 3, I want to give you an example. This is really important, just one, because they're all somewhat similar here. That's how we report them. Important to realize here that the grade 3-4 toxicities on both arms are less than 10%. Not surprisingly, we see the hypertension with VEGF-TKI. One of the issues here we continue to have when we have a VEGF-IO combination is the attribution, especially when you have a side effects that can be seen with IO or VEGF, LFT's elevation, hepatitis, not hypertension, LFT's elevation or diarrhea, for example. So it needs some art in managing, you stop the TKI, etc. Brian led this study with James Larkin from the UK, looking in a very systematic, detailed fashion at cardiovascular toxicity from checkpoint inhibitor. Here with Javelin Renal 01, looking specifically at avelumab, but also at the contribution of VEGF-TKI axitinib. I think this study is the one that, Brian collected the most data and the most biomarker of cardiac toxicity here. It gives you an idea about the major adverse cardiovascular event here. I think this is overall, if you look at it, lower than what we expected, especially with the initial myocarditis we've seen with checkpoint inhibitor and the TKI, VEGF-TKI toxicity. So still monitoring is needed, but in practice, I can tell you, in my practice, beside making sure the cardiac history, getting baseline EKG, that's what, I do. We do not get these cardiac biomarker, each time the patient gets like troponin, etc. So Cosmic 313, that was in Paris. It was raining when I presented this study at ESMO, trying to answer the question, is 3 better than 2? So we build on nivo-ipi in intermediate poor, and we add cabozantinib at a lower dose, 40 milligram once a day, lower dose than the full dose as a single agent. The study met its primary endpoint, progression-free survival here, 0.73, and Tom, in a couple of days, gonna present an updated result. Interesting enough, and I can't explain it yet, the patient with intermediate risk, 75%, had all the benefit for PFS and response rate. And obviously, when you add another drug to 2 that does on itself have side effects, you have more side effects. And I think I'm on time. I'm actually worse than Tom. I take more time.
You're good.
Yeah.
We were all threatened with death if we went over time. Oh, sorry. That's why we're all paying attention to time. So we're going to move on to third module about relapsed refractory kidney cancer. And we have a couple cases to talk about before we do that.
The next case is presented by Dr. Eric Lee.
63-year-old female with metastatic clear cell renal cell carcinoma, mets to the right lung pleura. Decision was made to put her on a combination TKI and checkpoint inhibitor. So I used lenvatinib and pembrolizumab. Asked the patient to please monitor her blood pressure at home. So I started her actually on antihypertensive therapy prior to starting systemic therapy. Now, she ended up with multiple ER admissions with refractory hypertension. I asked the patient to hold lenvatinib. She was very, very resistant doing so. She goes, if I don't take the medication, I can't treat my cancer. Finally got it under control. I mean, it took several months. My question to the investigators is, what's the next line of treatment after TKI plus immunotherapy? I know cabozantinib can be used with a TKI failure. I know there's a new agent called tivozanib now. In the old days, we would also use everolimus for patients.
When you were dealing with her hypertension, did you dose reduce the lenvatinib?
She actually never dose reduced. I recommended it a few times. I even recommended holding the medication a few times, and she just never did it. Just kind of a stubborn patient. But in the end, I think it worked out.
So the questions coming out of this case include the following. How do you screen for and manage hypertension in patients on TKIs? Also, how do you specifically approach dosing of lenvatinib when used, for example, with pembrolizumab? How do you approach patients who are resistant to reducing the dose of an oral medication because of concerns that it will decrease the anti-tumor benefit? In what situations, if any, do you use tivozanib? Is this agent also being combined with immunotherapy? In what situations, if any, right now are you using everolimus, for example, combined with lenvatinib? And exactly how do you use this agent?
So Laurence, let's start with you, that first question about managing hypertension. What's your general approach? And if you're giving len-pembro, what's your dosing strategy?
So I ask my patient to self-monitor their blood pressure and report that each time I see them in clinic. And I also have on a prescription a trigger for which they should start antihypertensive drug. With regard to lenvatinib, the important thing is to look for other toxicity, like checking your proteinuria, for instance, in such a situation. And in a patient, usually, if you combine different antihypertensive drug, you can remain on the full exposure to lenvatinib.
So you start at 20 milligrams of lenva?
Yeah, it happened to me to start at 18, but usually I start at 20, correct.
Okay. Toni, how about that second bullet point? So patients, as you well know, cancer patients want to take their drugs, right? And they'll sort of do anything, especially in the frontline setting. How do you approach this particular patient who says, well, gee, doc, I'm not going to stop, I'm not going to hold because...
I mean, yeah, no, I drive to their home, I go to the closet, I take the medication away. No, really, what I do is manage quickly the blood pressure here. This patient, if they went to the ER with hypertension, Brian, they need to hold the medication.
Yeah.
And there are patients, despite the best management of blood pressure, that are so sensitive to TKI, we've seen it, a minority, a really small minority, that they need a lower dose, otherwise they'll have RPLS or, stroke or anything. So sometimes it's playing with fire, having an SBP over 200.
I agree. Laurence, you want to add something?
Yeah, so in this situation, I think the question is the patient was reluctant to dose reduce. And in this situation, I usually explain the patient that it's like a long run process. And we don't want to have to discontinue because of side effect at some point. So I basically said, ultimately, if you remain the same dose, we'll have to stop treatment. What I want is to keep you under treatment.
Yeah, no, I think that's a good point. I think
The one thing that helps is to tell the patient you have 2 drugs on board. So stopping one for a short period is okay.
Right. Tom?
Yeah, I was just going to say, my interpretation of this whole piece is the management of toxicity is more important than the combination you choose at baseline. I think the debate of Axi-Pembro versus Cabo-Nivo is actually not a relevant debate. You can choose either, and they're both very, very good. The much more important question is, when patients are getting into trouble, how do you manage that to make sure that things don't go so wrong that you can't continue to give that therapy? And my concern sometimes is we spend too much time discussing the differences between these combinations, all of which have many, many more similarities than differences, and not enough time talking about issues around management of hypertension. Clearly, an individual who's refusing to stop Len 20 is a grown-up, that's a proper dose of drug. Not everyone, most patients, I think 75% of patients don't reduce. And that's a very complicated conversation. I'd be saying to her, listen, I want to give you any more drug until we've got this conversation right. And Laurence is absolutely right. There needs to be this conversation because the PFS is 24 months. It's a marathon, well, a marathon. We want it to be a longer and longer marathon. Mm-hmm. But, if she insists on going at 20 milligrams, this is all going to go wrong in a couple of weeks and it'll end up in an emergency room. And so this piece is as important as the choice of drugs at baseline.
Yeah, I agree. I would just reiterate, it's not about maximum dose in the short term, it's about adequate exposure in the long term. And I also will explain to patients that we started the same dose in everybody, which is, of course, a ridiculous strategy, right? Because it's not going to be the right dose.
It was your strategy.
It wasn't my strategy. We could talk about it later. It wasn't my strategy, but it's going to overdose plenty of patients, right? And clearly, if they're having hypertensive crisis, they have adequate exposure, right? And we, again, that's a whole other conversation. But I think you do have to talk patients through and realize that, as many have said, that we're playing the long game. I think we have one more case. Let's do one more case.
The next case is presented by Dr. Sunil Gandhi, a 64-year-old woman with widespread RCC and a VHL somatic mutation on NGS testing.
PET scan showed spleen mets and bone mets. So I haven't seen too many spleen mets, and I definitely would like to know how common is spleen mets with kidney cancer. I have seen it in melanoma. Hemoglobin was 8.9, so it made her intermediate risk. So I started on EP and Nivo. 3 months later, she came with dizziness, looking sick, did a CAT scan of brain stat and the single brain met. So I sent to neurosurgeon who did the resection, and then we gave radiation. Lung mets were better, lymph node mets were better. So I said, I'm not going to give any more EP. So I said, let me put on cabozantinib and continue my Nivo. So that's what I did. I don't know whether I did right or wrong. I want to know some expert opinions on that. But she has responded very well. She has very little disease left. But one of the things, of course, you do the NGS testing in all those people, and she has VHL gene in NGS testing, somatic gene, not germline. So I don't know whether any targeted drug for VHL gene is available.
So the question here is, how do you manage a patient who has good systemic disease control with ipi-nivo, but then develops new brain mets. Also, the potential role of belzutifan in RCC.
So let's talk about the bottom two. Spleen mets I've probably seen a few times, but kidney cancer can go anywhere. But Toni, let's start with you. So let's take any systemic therapy. You have a patient who's on ipi-nivo, IO, TKI. They're doing well. Their disease is responding, but they develop a new isolated site, brain, bone. Pick a site. Do you have a general approach to that patient?
Yeah, generally and almost invariably, I radiate, I treat, radiate or surgery, SRS, that site, and we've seen progression in the bone or in the brain. So that's what I have done and continue the systemic treatment.
Laurence, you're shaking your head. You agree?
Yeah, I think oligoprogressive disease, we want to go for focal therapy and remain with the same systemic agent. Here, a combination. I want to make a case around brain mets. There is a role for screening for brain mets. I know it's may not be routinely performed, but having either a CT scan or better an MRI when you start a new line of therapy makes a lot of sense to me, and especially with nivolumab, ipilimumab, where we do know that the response in the brain is low, and therefore you want to offer focal therapy, SRS, for instance.
Is there a limit? So let's say you do one focal therapy and 8 months later there's another bone met and you radiate that. I mean, is there a number of rounds of focal therapy where you say, well, gee, maybe I should switch systemic therapy?
It's the time interval to me that matters more than the number. If it happens 12 months later, that's fine with me. If it happens 1 month later, then you need to change your systemic therapy.
Okay. Toni, I think
the cutoff is 6 months, I think, arbitrary, and the number of mets. So if you have even, 10 months, 12 months later, but 3 or 4 new, that's it.
Sure. Tom, comment on your approach to what we've been talking about, focal therapy, and then I'm going to ask you to tackle that last bullet point there.
The last point, I think VHL alterations are actually quite common obviously in clear cell renal cancer. They're associated with HIF and VEGF, which is part of a similar axis. Belzutifan is a transcription factor to HIF2 alpha with single agent activity of response rates in the region of 25% in heavily pretreated patients. Spectacular results, in my opinion, in patients with germline VHL mutation, VHL disease, with primary renal tumors. I think it's the most aggressively developed new drug in kidney cancer. There must be 3 or 4 randomized phase 3 trials, adjuvant, second line, first line, pretty much everywhere. And I think it's a really well-tolerated agent because it's very specific. It's not associated with a biomarker. We're not developing biomarkers with this, which I think in the end may turn out to be an issue. I think in the future we should do that. I suspect it works better in earlier disease, which is more strongly VEGF driven, than later, which have heterogeneous pathways, parts of that phylogenetic tree associated with resistance beyond just VEGF.
That was my way of cutting you off, Tom.
Right,
You're giving my entire talk right now.
I thought it was an excellent...
Let me ask in the last 20 seconds, are you all doing NGS testing, and when, and do you find it helpful?
Not in kidney cancer.
You're not doing it at all?
Not in kidney cancer.
Okay. Toni, do it all at all?
I do it in non-clear cell.
Non-clear cell?
Non-clear cell too.
Okay. All right, I'm going to talk about refractory kidney cancer. So this is a table that just summarizes frontline. Toni told you all about that, but the point is the title, basically, that the vast majority of kidney cancer patients are going to get an IO-based regimen. Frontline, pick your favorite. And so what we're really talking about now in refractory kidney cancer is IO refractory, but we don't really have a lot of good data in that setting yet. The data we have, at least from a phase 3 standpoint, is represented here. These are studies now done a number of years ago, and these were in the post-VEGF TKI when single-agent TKI was the standard of care, Axi-Nivo, Cabo, and everolimus, and you've heard a little bit about these. And again, I think it's sort of, obviously with the exception of nivolumab, these are, TKI-based therapies. You get tumor shrinkage, you get PFS, in the 5, 6, 7 month range. Len-Ev stands out here. The first 3 are phase 3s. Len-Ev was a randomized phase 2, so take it with a grain of salt. And you can see toxicity differences. And for me personally, when I'm moving from an immune-based regimen to a non-immune-based regimen, I'm no longer thinking I can cure that patient. I'm just trying to control disease. So I account for toxicity probably more in a refractory setting than I might in a frontline setting. Tivozanib was brought up, so Tivo is the newest drug approved in this setting. This is Tivo-3. This drug has a long regulatory history we don't have time to talk about, but the registration study was this Tivo-3. This was in refractory, this was basically third and fourth line kidney cancer. It was approved relatively recently, small study that randomized patients who had had 2 prior treatments, including at least 1 VEGF TKI, and a significant subset had prior immune therapy. This study was conducted right as immune therapy was becoming standard in earlier lines to Tivo versus sorafenib. This is the primary endpoint of PFS. You see a PFS advantage here. I think one of the most impressive pieces of data from this study is sort of that tail of the curve, and I think there's a separate slide on some of the longer term results. And remember, about I think it was 27% of patients had prior immune therapy. So whether that influenced that tail, right? Even if you stop immune therapy, the drug and or its effects are around for a while. But either way, it's a well-tolerated drug that I use a lot in this setting. This is the forest plot of PFS. And again, remember, it's a small study, and I hate over-interpretation of forest plots. You definitely see a signal as you move from favorable to intermediate to poor. And I think that's probably because favorable is a more pure VEGF-driven disease, and tivozanib is pretty much a pure VEGF inhibitor, whereas sorafenib is a much more promiscuous drug, and I think you probably get other pathways as you move towards poorer risk disease. You can see kind of that second to the bottom one there, checkpoint inhibitor plus VEGF TKI, again, about a quarter of the patients, but a pretty consistent hazard ratio. So again, not a pure IO refractory patient, but at least consistent data in what is the largest subset to date as we wait for the prospective trials. And this is a really busy slide, but just a updated data, I think presented at ASCO last year for long-term progression-free survival as we follow these patients out over time. And I won't read this to you, but some nice long-term data. Overall survival has been hard to show in a refractory setting. The 2 trials that have shown an overall survival benefit were compared to everolimus, so Meteor with cabozantinib and Checkmate 025 with nivolumab. Anyone that had a VEGF TKI as a control arm has not shown overall survival. So I'm just sort of going through different salvage therapies here. This is work that we did when I was back in Cleveland. This was salvage ipi-nivo. So this is when ipi-nivo had been approved. The IO-TKI regimens hadn't been approved. And we had a number of patients who were on TKI-1, TKI-2, and then were failing. We said, gee, is there activity to ipi-nivo in this setting, to so-called salvage ipi-nivo? This is a bit of a complicated slide because it looks at their best response to prior immune therapy, but the response rate overall was about 25%. So we did see some activity, but unfortunately the vast majority of patients progressed. And I think we've learned, in the next slide we'll detail this, that ipi is not a great salvage agent. And if you're going to use it, you should use it up front. And sometimes, I will rarely do this in practice. This is sort of a desperation in a very young patient who hasn't had ipi before, but I don't think it's should be part of routine care. This is a summary slide for the role of ipi-nivo as salvage, so you may be aware the last column is the data I just presented, but the first 4 columns are studies that looked at nivolumab monotherapy with ipilimumab added in either at progression or lack of response at a certain time point. And they all did it a little bit differently, but broadly similar. You can see relatively small studies. And you see the response rates are relatively modest, generally in the 10-15% range, and a very low percentage of CRs. So again, I think this was a great idea. Like, can we just get away with single agent nivo in a group of patients that's super well tolerated and we'll only add ipi if needed? I think the concept is great. In practice, it didn't really work. And again, if you're going to give ipi, you really need to give it up front. And I don't think this is a viable approach in clinic. Probably the strongest data we have for the IO refractory setting now, this is the Keynote 146 study, Len-Pembro single-arm study, but a big multi-center study, 104 patients, all of whom all patients had prior immune therapy, and they got standard dosing of Len-Pembro. You can see sort of the breakdown there, a lot of ipi-nivo and then some IO-TKI as well. And these data are really quite impressive. Response rate of 55%, duration of response at 12 months, no CRs, but a high response rate. Of course, what we don't know is, is this from the combination? Is it just from the Lenva in this setting? We don't really know that because it's a single-arm trial. But I think it was the first signal that patients may have more than one shot at immune therapy. And that's really one of the main questions, in my opinion, in kidney cancer right now. So I don't do this in practice because I'm waiting for these 2 studies, CONTACT-03 and TiNivo-2. Neither have been reported. CONTACT-03 has accrued, TiNivo-2 is accruing. And you can see these are broadly similar studies that are looking at an IO refractory kidney cancer population. including patients who now fail adjuvant pembrolizumab. I know Tonivo-2 allows it. I think maybe Contact did as well. And you can see if you look at the treatment arms, it's IO-TKI versus TKI. So single agent TKI, pick your favorite, I think is the standard of care in the refractory setting. And this is looking at, is that combination of IO-TKI, will it provide value in that refractory, in that second line / refractory setting, PFS and OS. So I think the field anxiously awaits both of these trials to know if this is a viable approach or not. Belzutifan, we talked about, is a transcription factor for HIF, which is downstream of VHL, which is an integral gene in kidney cancer and drives angiogenesis. There's a number of data sets out there. In the refractory setting as monotherapy, they all show a response rate sort of in the 20-25% range. Doesn't appear to be too dependent on IMDC risk factors or others. So definitely some activity. And frankly, this is about the activity of TKIs in the refractory setting. They're broadly in that 20 to 30% range, so not terribly different. These are data that Toni presented last ESMO. So this LightSpark study was 2 cohorts of belzutifan plus cabo, so VEGF TKI plus HIF inhibition. Part of the rationale being is that when you inhibit the VEGF receptor, you may upregulate HIF, which can act via other pathways. So there may be a complementary additive role for these. I have the next several slides present first cohort 1, and then which was treatment naive, and then cohort 2, which was prior immune therapy treatment. So you see a response rate of nearly 60%. I thought these were really impressive data. Small number of patients, but pretty impressive response rate. Certainly higher than you'd expect for a belzutifan alone, probably higher you'd expect for cabo alone. And then just other data about percent change in tumor shrink. So clear activity, right? Clear activity to this combo. This was in a treatment-naive population. This is cohort 2. Remember, this is an IO refractory population. Of course, these are going to be lower response rates, right, because these patients have had treatment, but still impressive in the 30% range. I think the frontline data is even more impressive, even considering the relative context. So I think these were the first. These data had presented before, but in very small numbers. This was sort of more mature data that I thought was impressive, and this combination is being studied. This is just the other tumor shrinkage data. This combination is being studied, if you look at that bottom line there, belzutifan lenvatinib compared to cabozantinib in treatment refractory. So this is a large phase 3 second-line study. And that first line is the registration intent study for belzutifan. This is single-agent belzutifan compared to an everolimus control in a broad refractory population. So as Tom mentioned, belzutifan, I think there's 4 phase 3s, monotherapy, refractory, doublet that you see on the screen, triplet frontline, and then adjuvant. So it's being sort of scattered across kidney cancer, and so we'll see where it ultimately finds a home. I have exactly 0 seconds to present this slide to you. This is basically, it's a broad swath of kidney cancer and new targets, immune checkpoint inhibitors, metabolic drugs, anti-macrophage drugs, et cetera, et cetera. I think potentially the most exciting space in kidney cancer is that refractory space. We desperately need new mechanisms of this disease, and these are just some of them. And I'm going to skip because I actually went the most over time. Embarrassing. I think single-agent VEGF is the very unexciting standard of care. I think that's going to change if we're probably standing here in a year. IO-based combinations have activity, but we really need that randomized trial data. HIF inhibition clearly has activity. I agree with Tom. I think it'll ultimately find a home earlier in disease, but we'll find out, and a lot of things under investigation. So with that, we will move on. Thank you for your attention. And we'll move on to our next case.
The next case is presented by Dr. Nikesh Jasani.
He's a 69-year-old pleasant gentleman with Waldenstrom since 2011. He presented to the hospital with significant shortness of breath, chest pain, and was found to have bulky right renal mass and subsequent left pleural effusion with pleural nodularity requiring a VATS. Biopsy confirmed conventional RCC papillary. We initiated ipilimumab, nivolumab. He's completed 4 cycles, transitioned to nivolumab maintenance, had a partial response. Unfortunately, at the time of assessing him for consolidative nephrectomy, because he did have IVC thrombus, he was found to have brain mets and progression in the pleura. Questions I have for the faculty is, what is the role for nephrectomy in the current era of TKI and immunotherapy-based treatment? He's in the midst of finishing stereotactic radiation. My plan was to initiate cabozantinib on this individual.
Any questions about that?
Yep. And what is the best second-line therapy in these individuals?
So in summary, this 69-year-old man has disease progression on ipi-nivo and is now receiving cabozantinib. And the key question surrounds the choice of optimal second-line therapy in patients with metastatic papillary cancer receiving an anti-PD-1, anti-CTLA-4 combination. And another relevant question is the current role of cytoreductive nephrectomy in metastatic RCC.
These are big questions. So, Laurence, you're going to talk about non-clear cell, but maybe give us a preview how you're approaching non-clear cell in general and papillary in particular.
Thank you, Brian. So all non-clear cell are not the same. And papillary RCC, we have quite a number of different data supporting the use of single-agent TKI, including cabozantinib, which is the one that has been assessed in randomized phase 2, but also new agents targeting MET. So I think it makes a lot of sense that this patient is being offered cabozantinib because of a papillary RCC.
Okay. And Toni, maybe take that second one, approach in a patient who progresses on ipi-nivo. Then does brain mets influence your choice of systemic therapy?
Yeah, it does. Actually, cabozantinib is the treatment of choice here, based on for the brain mets, based on retrospective data that we generated with Dr. Albiges. IO only, nivolumab does not have activity in brain metastases. This is, or nivolumab, ipilimumab. This is, different than melanoma. TKIs, traditional TKIs like sunitinib, do not have really activity. And when I talk here, brain mets is untreated brain met, which is a very common problem outside the US, not major problem in the US since we can radiate quickly everyone. So cabozantinib is the way to go. And there is actually a phase 2 study led by the French called CabraMet, which is single agent cabozantinib in brain metastasis.
Toni, would you ever give systemic therapy? Would you ever not give local treatment to brain mets?
No.
You would always give local treatment?
Yes.
Laurence?
In 90% of cases, I have local treatments, but I have seen patients that had more than 10 mets in the brain. And then in this situation, I don't use whole brain radiation therapy. It doesn't work well. I use systemic therapy. And then I would eventually use radiation therapy to the largest ones.
All right, Tom, I'm going to give you 30 seconds to talk about cytoreductive nephrectomy. Good luck.
Okay, so I'm not a great believer. I think the data doesn't support doing the cytoreductive nephrectomy in clear cell kidney cancer. There are some subgroups of patients with a low metastatic burden and a big symptomatic primary tumor, which I think cytoreductive nephrectomy still has a role despite the negative Carmina trial, which compared nephrectomy and no nephrectomy in advanced disease with sunitinib. I think in papillary renal cancer it becomes even more uncertain, and I think therefore if in doubt don't do it because it's a big operation. So again, unless the patient had a big symptomatic primary with small metastatic burden, I wouldn't be doing a nephrectomy, and clearly an individual with brain metastasis, I wouldn't be doing a nephrectomy.
Yeah, sure. It's a big topic. We don't really have time to cover. We may talk about it after, but it's a big topic that I think is evolving. I think we have one more case before. Yep.
The next case is presented by Dr. Georgia Zazi, a 71-year-old woman who presented with metastatic disease after a prior radical nephrectomy.
She had actually a history of autoimmune disorder with psoriatic arthritis, hypertension, and presented with clear cell RCC that had recurred after 18 months of nephrectomy for PT2. She had mets to the mediastinal lymph nodes. The IMDC was good risk, so we started her on pembro-axi back then, and she developed an LFT elevation about two and a half months in. The LFTs were into that 300 to 400 range, and then we stopped the axi, and that went back to normal after about 10 days. So, I assumed it was from the axi. We resumed the axitinib at a lower dose, and she tolerated that well, and then eventually achieved a complete response. Eventually, the axi was discontinued because she was reporting fatigue, and then the patient was already in CR. And after 1 year, the pembro was also discontinued because her psoriasis and psoriatic arthritis was getting really bad, and she was in CR. So I said, I will closely monitor and see what happens. She remains now 2 years later, and she remains off therapy. I do want to know, what is their cutoff about autoimmune disorders they would consider like an absolute contraindication for IO, and which ones would they try to work with their like rheumatologists or gastroenterologists and still try to get them onto immunotherapy?
In summary, Dr. Aziz is bringing up the issue of the bar to use immunotherapy in patients with prior autoimmune disorders, and we can add in the complementary issue of patients with prior solid organ transplants.
So I think I'll probably ask all of you, because I think we have different practices. Perhaps, Laurence, I'll start with you. So let's just take immune-mediated disorders in general, right? Pick your favorite. What's your threshold to say, I'm not going to give immune therapy, I'm too uncomfortable, versus, as the Dr. Aziz said, like, well, maybe I'll just send him to the rheumatologist and feel more comfortable, but I still want to treat him. What's your threshold?
So once again, these are the kind of case we discuss in our IO tox tumor board ahead of a treatment, and we find a way for the patient to be seen by the specialist of the autoimmune disorder, rheumatologist, or other one. The one I wouldn't challenge with IO are the life-threatening one, patient that had a history of Lambert-Eaton disease or myasthenia, I wouldn't go. But I've treated patients with Crohn's disease with IO. That requires a lot of monitoring here with a GI specialist, of course, but we try to expose our patients.
Toni, what do you think? What's your threshold? How brave are you?
I'm very brave in general, and bravery comes with experience and hair loss, all that. So I think overall, I definitely team up with rheumatologists. One of the things that this field created is these, very highly specialized non-oncologists that started to know way more than us about this. So psoriatic arthritis, is it severe? What's the percentage of the body involved? Does it involve really significant arthritis, etc.? Or is the patient on just low-dose methotrexate? That is different. The one that is I'm not brave enough to do, like Dr. Albiges, is those Crohn's disease that are barely, controlled, risk of perforation, etc.
Mm-hmm. Tom, anything to add? What's your general approach?
So I guess it's all about risk-benefit ratio. So in good risk patients at the moment, there doesn't seem to be a huge overall survival benefit for immune combination therapy. So you might say if there's active autoimmune disease, why not try sunitinib instead of an immune therapy? In intermediate and poor risk disease, you might want to go for a VEGF-TKI-IO combination rather than IO-IO combination, because there's probably going to be less immune-related tox associated with a VEGF-TKI than a CTLA-4. PD-1. The adjuvant setting, again, the risk-benefit ratio needs to be discussed. You probably have a lower threshold to not give therapy. So probably you give patients, sorry, let me make it more clear. You probably have a threshold to give less therapy for patients with active immune disease in the adjuvant setting, because the benefits are probably less clear. Overall, I think we've got into a situation where we're more comfortable treating patients with immune disease than we were 4 or 5 years ago when they were all contraindicated. And I think some interaction with other healthcare professionals, rheumatologists, etc., is relevant in this setting.
So we just have a minute left. I'll take the second question. If I can talk for hours on AXI titration. If any of you can't sleep later, let me know. I'll give you a talk on TKI dose modification. But I think even if you just broaden it, not just AXI, somebody once said, the goal isn't to take pills every day for patients, right? The goal is disease control, right? And we've talked about stopping, and so interrupting dose is great. I give a lot of drug holidays. There's no magical dose, right? We don't know what the magical dose is for an individual patient. AXI is more titratable, but I think the same applies to the other TKIs. And I do a lot of playing around with dose. My personal opinion is they're more important early on, as we've sort of heard people say, early on for disease control, and I think they become less important over time. That's probably biology dependent. We don't have a great way to measure that, but I think what this doc did in this case was exactly right. We see a lot of LFT elevations with these IO-TKI. Stop the TKI unless the patient's very sick. Most of those patients will resolve without steroids. I was giving a ton of steroids early on with Axi-Pembro, and I give very little now for LFT abnormalities. We are exactly on time. I'd like the record to reflect, and we're going to go to Dr. Albiges to talk about special patient populations.
Thank you, Brian. Once again, it's a pleasure to be with all of you here tonight. So I have been asked to cover the question of special patient population that encompass the different situation. Non-clear cell, specifically a focus of papillary RCC. What is the role of combination IO plus VEGF-TKI that we've been discussing with clear cell RCC? And then a few words on VHL and HIF role in VHL disease. So let's jump into non-clear cell. The first thing is non-clear cell is actually different entities that emerge from distinct parts of the kidney. And second thing is they have different clinical features, but also molecular alteration and distinct pathway deregulation. So we should walk away from considering all of them in the same bucket. The third point is that this is evolving over time. The WHO classification defines RCCs, and among them, if you look at non-clear cell, it's evolving. For instance, in the most recent update, papillary is considered as a single entity, and we see appear what is called molecularly defined renal cell carcinoma, which is a good news because it means that we're getting better in understanding the underlying biologies of those different entities. One thing you need to know about non-clear cell is it has a poor prognosis. When compared to clear cell, these are IMDC, VEGF-TKI era data. But the bottom line is that the life expectancy of our patient is about half of what we have with clear cell RCC. So there is a need to do a better job for those tumors. What about papillary? Papillary is the most frequent form of non-clear cell. From the TCGA work, we know that it's not one entity. There are at least 5 different subtypes. And type 1 RCC seems to be driven with what we call MET alteration. Type 2 RCC, previously named type 2 RCC, different clinical features presentation, including very aggressive disease in some kind. So there has been dedicated trial to papillary RCC. And this is 3 examples, mostly VEGF-TKI. What you had with single agent was a response rate that is actually pretty low, between 12 and 25%, and a PFS that less than 6 months. So we can do a better job. Doing a better job starts by randomizing patients. And this is a SWOG study led by Monty Paul, which randomized patients either to sunitinib, considered as standard of care, with 3 other agents. 2 arms had to be dropped because of futility. But ultimately, the readout of this phase 2, with PFS being the primary endpoint, is that cabozantinib changed the threshold of, let's say, 6 months with sunitinib up to 9 months with cabozantinib. And that explains why cabozantinib is now in the guidelines as the preferred option for all-comers papillary RCC. And to your right is the response rate, clearly higher with cabozantinib than sunitinib. Now, what is great news for the field is that there has been the launch of phase 3 that were biomarker defined within papillary RCC. And the Savoir study led by Toni was the first of its kind. Patients had to be screened for MET alteration that would represent about 30 to 40% of patients with papillary RCC, and randomized between sunitinib standard of care and savolitinib, considered as a more MET-specific inhibitor. To put a long story short, those tumors are not that frequent. Having a screening in some patients that have rapidly aggressive disease is not easy, and it takes time to enroll those many patients. So the study was closed earlier on because of pace of enrollment, but here the findings are the following. It seems that savolitinib derived a higher benefit both in terms of PFS, but also on overall survival in a small numbers of patients. Savoir is now followed up by a SAMETA study that is up and running, and ultimately this phase 3 will define what is the right setting for MET and MET plus IO inhibition in papillary. Jumping on to the question of combination, VEGF-TKI plus immune checkpoint. We have single agent immune checkpoint inhibitor data that have been presented. And actually, pembrolizumab paved the way here with a large phase 2, non-randomized, but showing quite an interesting response rate, 26%. There was all non-clear cell, but a large bucket of papillary in there. And we had dual IO-IO data that have been reported here with data that are very preliminary. We are all waiting from a randomized study that is actually academically led from Germany, Sunny Forecast study, which randomized patients between standard of care, choice of an investigator, and nivolumab plus ipilimumab. And that will answer the question that we had in a case here. In papillary RCC, shall we go for nivolumab plus ipilimumab? Or is there another subtypes where doublet IO makes sense? Last ESMO, I presented the first results of lenvatinib plus pembrolizumab in a setting of non-clear cell frontline RCC. What is needed to be stressed here is that these are very preliminary data, only 82 patients, but ultimately more than 150 patients have been enrolled. And what is interesting here is that we demonstrated a clear high response rate with this dual combination, with a response rate almost reaching 50% and a high disease control rate of 80%. So, compared to historical data, we're doing a great job. Second information is that it seems to work both in papillary, in unclassified. However, the response rate in what is called chromophobe seemed on this first analysis to be quite low. So that picture is here to depict the different agents that have been tested in non-clear cell in the quite recent cohorts. And as you can see, it seems that lenvatinib plus pembrolizumab is adding into the game, as well as cabozantinib plus nivolumab recently demonstrated as well. There are randomized data that are now being constructed and being built, and the STELLAR 304 study is a phase 3 registration study looking at a combination strategy with the new potent VEGF plus MET inhibitor XL092, and this will be compared in combination with IO. This will be compared with sunitinib standard of care. Now, one word on VHL disease. So all of us don't treat VHL disease, germline VHL disease, routinely. So I depicted on this picture what is the spectrum of the different abnormalities that can be seen in a patient that have inherited VHL disease. Among them are renal cell carcinoma. And why is it important to stress that? Brian touched on the role of HIF inhibitor and mechanism of action. What I want to depict is that patients that carry VHL alteration, meaning in this situation here, in the bottom of the slide, VHL null, meaning deficient cells, have a high expression of HIF2 alpha that induce the upregulation of all the neoangiogenesis pathway. HIF2 inhibitor, and namely belzutifan, who opened the way, is here to prevent the dimerization of HIF2 alpha with HIF1 beta, and therefore should reduce all the downstream genes that are being activated. What we know about this strategy is that it is extremely active. It was published in the New England, updated last ESMO. It's only 61 patients. However, the response rate of 64% is actually extremely high in VHL disease-associated RCC. This strategy changed the pace of the growing disease, RCC disease, in those patients that have VHL inherited mutation. And this cartoon depicts the fact that those patients do not require any more surgery related to their disease. So the fact that they are being exposed to belzutifan prevent the need of further surgery, irrespective of RCC, pancreatic, or other lesions. With regard to safety, no more words than what we've heard. It's a well-tolerated agent, and the only related to mechanism of action toxicity that you should have in mind is anemia. So my take-home message are the following. Non-clear cell are not all the same. With papillary, we're doing a better job with a tailored approach, including MET targeting. We clearly are defining the role of combination in all the non-clear cell subtypes. And for VHL disease, I consider that HIF inhibition is a standard of care, and you're lucky because in the US you have access, while in Europe we don't yet have access, and this is an unmet need. Thank you very much for your attention.
So I just want to close by thanking you all for your attention and thanking Dr. Albiges, Choueiri, and Powles for their excellent talks and commentary. Thanks for attending.